the cerebellum is blurred, suspect on the presence of blood outside the cerebellum. And we are going to finish with the second part, which is the chronic phase. So normally we are going to see an asymmetry in the cerebellum. So how can we work up for cerebellar asymmetry? Again, check for the cerebellar morphology, check for signs of vermian involvement, signs of other conditions related to the differential diagnosis, and the presence of CNS lesions associated. Very important to know how to scan the posterior fossa. If we do a central insonation, we are not going to have enough resolution in order to check for the normality of the posterior fossa. I will try to go out of my laser point here. We need a very good resolution in order to be able to define that the upper aspect of the vermis is normal with the fissures. The primary fissure is here, but the inferior aspect of the vermis is affected. And if we are not sure if this anatomy is, it's very important to use 3D MPR imaging in order to reconstruct the cerebellum in the midline and to be sure that we are facing the vermis. And then, okay, I cannot achieve a anatomically normal vermis. And this is very, very important for us to establish the involvement of the vermis, which will be one of the most important prognostic factors. So again, the MRI will help us identify if we have a normal vermis. Here we have a asymmetry of the cerebellum. So the MRI depicts that this hemisphere has bled, and this very well performed MRI shows a perfect image of the midline that many times is deviated. So the technician need to know how to perform the exam to show that, and then we can scrutinize the anatomy of the cerebellum. On the other hand, here we have a small impairment of the inferior vermis in another case of cerebellar asymmetry. Additional findings are also important in order to prognosticate. So again, asymmetry of the cerebellum. And here we have an IVH grade 3 with unilateral ventriculomegaly. Here we see the three-horn views of this lateral ventricle. So this changes the prognostication of this case. And we have spoken about the term unilateral cerebellar hypoplasia that I like less. Another option that we have is whenever a part of the asymmetry, we also have this communication between the fourth ventricle and the cisterna magna in a Dandy-Walker-like fashion. And we should always remember the Faces syndrome. The final diagnosis of Faces syndrome is postnatal because it requires the presence of a facial hemangioma. Important to notice that not always on the day of birth we can see this hemangioma. Sometimes after the first weeks of life, then the hemangioma really appears, and the association with posterior fossa malformation, cerebrovascular anomalies by many means, aortic coarctation and other cardiac defects, eye, endocrine, and sternal abnormalities will lead into the diagnosis of Face syndrome that must associate the hemangioma and one major or two minor findings. What happens in pregnancy then? We cannot see the facial hemangioma. So this finding on the cerebellum will be the highest suspicion on the presence of Face syndrome. And we have this tilted telephone receiver shape of the cerebellum with the open fourth ventricle, and not always we can see, but there is this degeneration of this hemisphere leads to a cyst. But here the insult to the cerebellum is not hemorrhagic but ischemic because of the abnormal development of the vasculature of the posterior inferior cerebellar artery that we have spoken in the beginning. So again, the telephone receiver and the communication between the fourth ventricle and the cisterna magna. Sometimes the TCD is small, but not always. Another case at 26 weeks, with the same shape, the differential diagnosis also with a big arachnoid cyst that displaces the cerebellum, but most cases are sent because someone thought that there is a Dandy Walker a malformation. And here the MRI will not show signs of hemorrhage affecting this hemisphere. And this is one of the important insights. And for us to make the differential diagnosis, we can use highly sensitive Doppler in order to demonstrate the abnormalities of the inferior cerebellar artery of the affected side. There are other vascular abnormalities associated to faces. And here we have published then the criteria to suspect on faces syndrome in pregnancy. And there is this recent publication from Moran that we'll speak later on the prognosis about the craniocervical vasculopathy in children with a face syndrome. But this sign is very, very suggestive, and we need to remember in the differential diagnosis of cerebellar asymmetry. So it can be post-hemorrhagic, and we don't know why this hemorrhage occurred. It can be after severe anemia or by direct damage, either by parvovirus or CMV, because the damage by infection is not symmetric, and the telephone receiver of the faces syndrome. And I'll be here to answer questions. Hope we have given you some tools to take home in the workup of these challenging entities. Thank you.
Thank you, Karina, for your excellent talk, as always. So precise, to the point, and excellent images. All sorts of cases, what you want to see on for any malformation, you see the list of malformations right there. Absolutely amazing talk. Thank you, Karina, for. And now we are moving to our next talk by Gregor. Gregor he's a professor of radiology in Austria. He's working with Daniela Pryor, and he's going to discuss the role of MRI in case of cerebellar malformations and intracranial hemorrhage. I'm sorry, it's on intracranial hemorrhage.
Yes, thanks a lot, Prashant. It's really a pleasure to be here. I think the topic you have chosen for today is a very important one and is really underestimated factor so far and really deserves more of our attention. So my role is to talk a little bit about MRI in this condition. I'm
Sáng giờ nó cũng sóng gió với chị luôn. Hai chị em ôm nhau khóc luôn.
With MRI of fetal brain hemorrhages that we actually do not know a lot. If you go into the literature and PubMed and
5 cái MRI, 2 cái CT bụng,
you will find about 52 results, which is not a lot, and most of them happening
sao vậy không biết nữa.
being published in the last 3-4 years. However, there is a field where we know a lot of MRI and hemorrhages. That is the field of neonatal MRI.
Giống như con mèo gì đó, mèo chiêu tài vậy phải không? Má, thiệt luôn.
Hemorrhage is a major and severe complication of neonates. So we can learn something there in this field, which we can then translate also to the fetal arena, not entirely.
Sang chấn tâm lý quá. Trời, em không biết nè. Chị mua 2 giờ chiều chị mới nhớ ra là chị chưa âm chưa. Cái xong chị đi thì nó tới 2 chiều nó mới xong đỡ bệnh. Cái chị mới nhớ, chị thấy cái bụng chị kêu vậy mới nhớ chị ăn chưa. Cái chị đi mua bún bò ở trên mạng. Cái nó giao về nó còn không cho chị chén, muỗng, đũa, đĩa. Em thấy chị ăn bằng cái gì không? Chị đi chôm của người ta, cái ly của người ta uống nước. Chị đổ bún bò vô đây chị ăn. Chị đang ăn luôn. Thằng Phong nó kêu chị ơi, 5 ca siêu âm đang đứng xếp hàng chờ chị. Cái chị phải đi đổ hết cái đống này để chị đi siêu âm 5 ca. Là mới xong tức thì đó.
MRI is a very good tool in assessing the white matter. That's what we know, at least from postnatal series, where we've seen that there is about 25%
Sự bất hạnh của bạn là niềm dinh dưỡng của mình chị.
Đúng đấy. Bệnh viện họ rất thích có thứ gì thiên luôn. And we also know that
nhưng mà nó có vị ở cũng nó có thật với gì cảm giác như hồi xưa em làm việc vào người ta đi tiếp tục mày đó nhưng
Cái này
review article from 2017.
không bao giờ thay đổi.
Now, detection, extent, and outcome prediction, these are the fields I believe also fetal MRI can add to fetal neurology as well. And I would like
Công nhận từ bữa lúc mình bắt đầu trực tới giờ không có một cái đêm nào mà mình
here we have a problem.
Nên là không có thể
Actually says
chị năm đấy nhỉ?
fetal neurosonography
em thì đắp chăn ngủ chị đi siêu âm thai.
This is a large study from Amsterdam, which is frequently cited, and it basically came to that
Bên
conclusion.
kia giường chị tôi.
There's just one issue with this approach. That is, basically all the literature we have in neonatal is against this opinion. So this is basically a little bit contradictory. One reason for that is the MRI method used here. They used T2-weighted and T1-weighted sequences and
Có lẽ vì vậy mà hay bị
but
chật
they did not
đông không?
use a sequence which is
Bạn muốn học quá cho nên mình sẽ show cho bạn học.
susceptibility. Now, this term is really a tongue breaker. It's hard to spell and to speak, but I really want you to remember that term, susceptibility. What is it?
Chị nghe cũng ok.
Substances are susceptible to magnetic fields, and
Chị để trong này.
susceptible to
Mà quê em nói giọng đó là giống mẹ chị á, mẹ chị quê ở Hà Tĩnh.
magnetic resonance.
Em là gì Hà Tĩnh?
Is a tool to visualize
Mẹ chị là Hương Khê.
susceptibility.
Nhà chị toàn giọng đó, giọng em không á.
It contain a lot of iron in our body. Most of it is
Nhưng mà chị nghe giọng em quen rồi.
within the hemoglobin.
Nhà chị toàn nghe giọng đó suốt ngày từ nhỏ. Dạ.
It is basically magnetic. And
Tại vì ở nhà là chị người ngoài chị, tại vì học trong này cho nên nói cái giọng của cô dạy trong này, chứ thật ra ở trong nhà thì chị nghe giọng Bắc á, nên là cái giọng của chị nó không có nam hẳn.
Now, one thing to know is that the hemoglobin of a fetus is different from that from an adult. So we cannot fully translate what we know from postnatal series to the fetal series. However, there are some analogies. However, please keep in mind, fetal hemoglobin is very effective in binding oxygen, and it basically does not transform to deoxyhemoglobin so easy. So the timetable we know from postnatal MRI studies might not fully apply to fetuses. That's something we really need to learn also for the future. There is no data on that out there yet. Well, why is this important? I give you this case. This is a case at 36 gestational weeks. You see the ventricles are white and there is some hemorrhage going on in the choroid plexus. When you look at these images, to me, I would say, where is the blood? I do not see any lining of blood on the ependyma here. I only see the blood here in the choroid plexus. So probably there is some sort of obstruction also of the aqueduct, which on the T2-weighted image here is patent. I do not see any blood degradation product there on T2-weighted sequences. And that is very important. T2 has a certain sensitivity to iron and hemosiderin and blood breakdown products, but it's not the most sensitive sequence we have in our MRI. The most sensitive sequence we have is the echoplanar sequence, and this is a sequence which is basically showing the lining of the ependymal hemosiderin here along the cerebellum and the brainstem very nicely. So to actually see the full extent of the hemorrhage, MRI is very, very useful. And we actually looked at our 108 cases with hemorrhages and compared T2-weighted and EPI, T2 star, these blood sensitive susceptible sequences to each other in order to understand how many hemorrhages we would have missed if we would have not done this particular sequence. And actually that's what came out. You see here on the T2 no sign of any hemorrhage, but clearly on the T2 star you see a hemorrhage along the caudal groove here in a typical location. Same thing also the case here. No sign of hemorrhage seen on that one, just ventricular asymmetry, but here clearly the blood breakdown. So we see 30% more hemorrhages using the T2 star EPI image, and that is a very simple sequence. Every scanner has it. You don't need any upgrade or whatever. You can just run it. And by the way, it's probably one of the fastest sequences we ever have. It's like 10 seconds, and you have your images, and they are in the meanwhile also in the guidelines for the performance of fetal MRI. There's another technique which can help you out because we realized that sometimes EPI can be oversensitive. I give you two examples. Again here, you might think, well, there is some hemorrhage here. Looks a little bit, let's say, atypically ganglionic eminence here. Here on that one you see ventricular asymmetry. Is there really blood there? I don't know. Well, with EPI, it's a little bit clearer, at least here. You clearly see that there is blood breakdown products here. This is the susceptibility sequence. You also see the blood here, and even here a little bit. So really, this is very sensitive. On this side, you may think that there is some ependymal lining here which is dark and also blood, but it's hot. And if you run a newer sequence here, the SWI sequence, the hemorrhage here is clearly confirmed, whereas here you do not really confirm it. So I see the potential of this rather new susceptibility graded imaging, which is not available to everybody, which is a new development on fetal MR, in the fact that it has a very high specificity to the hemorrhage. So your wrong positive cause on the EPI, which is maybe oversensitive, are being reduced. Now, coming back to the situation Karina has shown you, and I think it's a very important point Karina has made, is how are you describing fetal asymmetry or fetal cerebellar asymmetry? Are you calling it hypoplasia or atrophy? And I think both terms are not applicable here. This looks like clearly like a defect. And it's like something has been bitten out of the cerebellum. So this is some classic defect here, and this is at 29 weeks. Does this tell you anything about the origin? Well, you can assume it, but you would never have thought that the original hemorrhage has been that large. So this is at 21 weeks. We follow that case up to 29 weeks. You see that
Chị thuê nhà anh Khôi á, biết không?
hemorrhage in the cerebellum
Ở Nguyễn Tri Phương á.
within 3 days. So most often, as Karina mentioned,
Đối diện luôn, căn của nhà anh đối diện, bên này bên kia đường luôn. Southside Slum. Hay là về Nguyễn Tri Phương đi chứ ở đây tôi sống giam không.
Bên đây xong cái nhà tự mình chứ. Được chưa?
Đúng. Bấm vân tay xong rồi có giao ban thì giao ban một chút vì về nhà nấu cơm ha.
Tiền dơ cái nồi cơm nắm đó rồi.
Không phải biết kìa. Nói bác sĩ Trang đi tại giường. Cũng là đi tại giường nhưng mà là giường ở nhà ngủ.
Your slide is still on. Now you're off.
Bác sĩ Trang đi tay bị điểm chứng minh chưa?
So now you should see it again.
Yes. Go ahead.
Unfortunately, I don't see my slides, but yeah, now it's going. Okay. So this is a quote from a neuroradiological journal where they compared ultrasound and MRI and actually could show that. So how is this applicable in the clinical scenario? This is at 30 gestational weeks. Again, you see there is a cerebellar asymmetry. If you now run T1, you might see slightly hypointense remnants, methemoglobin remnants there. But the really informative sequence is the susceptibility weighted sequence T2 star, and you see these hemosiderin remnants there. So these are the remnants of the hemorrhage. You know that at 30 weeks. It's not an assumption, you actually see it. And so this is not a Dandy Walker malformation, clearly. These are the remnants of hemorrhage, and that is how this hemorrhage was looking originally, as also Karina showed you before. Now, what happens to these cases? Well, they might not have a very bad outcome if the vermis is intact. Also, as Karina showed you, this is Sophie now at the age of 5 years, and she's doing quite well after her cerebellar hemorrhage as a fetus. And even note that her motor abilities are quite okay. Now, with the T2 star sequences, you are also sensitive to multifocal hemorrhages, and that might help you in the differential diagnosis. You see here a case with multiple defects of the brain, and also in the T2, you even can assume that there are small defects in the cerebellum, but you might not be sure. And if you have your T2 star, everything is
không, chị Chuyên Nhi, thai với Nhi mặt bệnh nó giống nhau nên chị học bệnh thôi, còn thai chị không có học, chị không có đọc ra thai.
Chuyên Nhi chị học thực tập ở bệnh viện Nhi Đông đó.
Chị làm ở Nhi Đồng đó giờ.
I just trying to make one point here.
Bệnh nặng lắm, nhưng mà mặt bệnh nó cũng đặc thù phía bên Nhi nữa, chứ nó không có giống bệnh ở đây.
We also know now a different side of hemorrhages, which is which recently came.
Trời, tối hôm bữa chị chụp, tuần trước chị chụp đó, tối á, em ra hai mắt chóng mặt quá trời.
Below the pupil surface, and which is compressing actually the cortex and also the medullary veins. And this sort of subpipal hemorrhage is often also ischemia and radiation cortex. One side is absolutely looking very much like the hemorrhages shown by Karina today as well. The side of hemorrhage in the cerebellum is sitting at the cerebellum, exactly where Karina showed you between the great microarteries.
Ủa nhưng mà bệnh cấp cứu thì chả lẽ ra đường vậy hả?
Ông đi cái chuyện đó rồi anh không đạt được cái chỉ tiêu. Bây giờ là về Biên Hòa.
Bệnh viện nào ta? Xin mắc á.
Nó chỉ là một thành viên thôi.
Em ăn.
Very abnormal, but also we frequently found hemorrhage residuals in the brains of these SARS-CoV-2 infected fetuses, going along also with placental thrombosis and even sometimes infarction of the neonatal brain with placental origins. There's another condition where most of the people are not expecting to see hemorrhages. Hemorrhages even are a contraindication for fetal surgery in the TRE2 malformation. But read the recent literature and you will find out that hemorrhages occurring in TRE2 are actually very, very frequent. Never described by ultrasound before, but on MRI we see them very, very frequently. And you see that also on the post-mortem MRI. And actually, in our series, there were 30% of all our cases with 91 cases with TRA2 showing blood degradation products lining the ventricle. In order to tell you that this is not an invention from Vienna, this is the paper from Philadelphia telling you basically the same thing. Now, we tried to find out why this happens and did this connectome analysis. I'm not going into the details. I just want to point out that the Chiari malformation is very complex, but one part of it is intracranial hemorrhage. It co-occurs with other features of the Chiari2 quite frequently. We think the origin is that there is a pleural sinus stenosis due to the hypoplastic posterior fossa. There is a congestion of the veins causing a fetal brain edema. Congested brains are very, very susceptible to have brain hemorrhages. So we believe that this is the mechanism behind that, and this is the link to the recently occurred paper in that field. The similar mechanism we also believe is happening in some cases of premature rupture of membranes. This is a very, very frequent condition and therefore much more relevant than the Chiari2. And we know that intraventricular hemorrhage in preterms occurs in about a quarter of cases, even nowadays. The incidence went down, fortunately. But when we were looking at our fetal series, we found that even prenatally, in cases imaged because of premature rupture of membranes and assessment of lung volumes, we found in the brain that 5% of those cases were already showing signs of prenatal intraventricular hemorrhage at prenatal stages. We also believe that has something to do with venous congestion of the brain and brain parenchymal edema and some susceptibility to these hemorrhages. Now, the question is, what is the outcome? And you all know the grading of Lucille Papil, and this grading is coming from 1978. This is important because 1978, Lucille Papil did not use the high-end ultrasound machine. She did not even use MRI. She used computed tomography. That is the original paper on which the grading is based. So this would be the grade 1 hemorrhage, that would be the grade 4 hemorrhage at that stage. I believe all of our ultrasound images and MRI images have a higher quality than this original grading system, and there is an urgent need to improve and adapt our current grading systems to our current imaging potential. One try has been done now almost 20 years ago by including the location of the hemorrhages here in this ultrasound study as well. And this is the newer proposition that we should get away at least from this original Papil system to the current system, which has changed the grade 4 hemorrhage to PVHI, periventricular hemorrhagic infarction, taking account to the fact that the brain is not always damaged by the hemorrhage itself, it's also hemorrhaged by the infarction. And this is the mechanism. You see the hemorrhage, and this is obstructing the veins. Again, congestion, again, venous infarction, lesion to the brain parenchyma and the corticospinal tract, and this is the result we see usually postnatally. And that has been accounted for in Efrat Haim's paper and proposition to really think again about this condition and take into account why these fetuses have their hemorrhages, and also taking into account the site of the hemorrhage, the location of the hemorrhage, which, in my opinion, plays a major role in the prediction. And this is also the problem. Dividing the brain just in 4 areas is a very crude anatomical definition. MRI can provide a little bit more information here. Even advanced neurosonography could describe some certain anatomical involvements better than before. We need to advance here. These 3 neonates would be all nowadays called PVHI growth parameters, but you can imagine that their outcomes are clearly different. We have tried to account for that in the postnatal arena, where we developed the scoring system, scoring different anatomical sites, and you can see those two different fetuses have clearly a total different ability to develop severe cognitive delays and are totally in different outcome fields. And that's what we need to translate also to the prenatal field as well. I give you, in this case, 30 weeks. You see that there's a dark spot here. Well, you could say there is some little hemorrhage there. You see also that there is asymmetry of the ventricles. This ventricle is here larger. So think about the proposed outcome here. Before you do that, I really recommend you do the EPI start. Certainly, you can see the extent of the hemorrhage much better here. Now, still, you don't know much. You may think that this is going to have a good outcome. I would say there is not a huge gap. But let's go to the original images of the original hemorrhage. And that's how it looked like at week 25. It was really, really clearly much larger than what we saw here. And you saw also there is an involvement of the parenchyma, there was edema, there was there's a high likelihood of involvement of the corticospinal tract, which at the 30 weeks was somehow indicated by the fact that this baby was not really moving her right hand. So there were already signs of hemiparesis prenatal. A tool which might help us to better in the assessment of the corticospinal tract was published by EFRAT very recently in collaboration with us, where we did tractography of the corticospinal tract and looked if the hemorrhage has actually involved the corticospinal tract. And what we found is, if that was the case, there was a much higher likelihood, multiple times higher likelihood for motor impairments than compared to those cases where we did not find any involvement of the corticospinal tract ipsilateral to the hemorrhage. And that's how it looks like if such a hemorrhage is at least partially involving the corticospinal tract on the affected site. So we believe this is a useful tool in helping us in outcome prediction. You also know that sometimes hemorrhages will cause cortical abnormalities like polymicrogyria as a consequence of a hemorrhage with total destruction of the corticospinal tract here in green on the affected side. This polymicrogyria we also often find in twins after twin transfusion syndrome combined with schizencephaly. There it is very interesting that the outcomes in those conditions might be not as bad as the images are looking. I show you now these twins here. What was the consequence after birth? And there's the image with the destruction of the schizencephaly on the right side, clearly involving the motor cortex. Prenatally, even not much movement of the left side. And these are the twins postnatally, and you see one is totally healthy, the other has this defect, and I could not tell them apart. There's really mild hemiparesis. So there is a lot of plasticity still going on.
Nhưng mà tốt dụng các bạn em coi lại cái chương trình em thì có những cái ca sĩ cũng tao đi cái con lạnh anh đi trong một mà tiêu chuẩn có đủ đi đến cũng phải cái khác không
So coming to the end, I think MRI can help in the detection, particularly when we are talking about subtle images, but we need to use EPI, SWI, or T2 star sequences. Use the power of MRI to be susceptible to iron and blood breakdown. We have to look at the extent. We know that there are some conditions with a very high high rate of intraventricular hemorrhages, which has not been recognized by ultrasound so far. So I believe that the extent of hemorrhages can be judged by MRI very well. And the outcome prediction, I think papille is somehow history. We need to adapt for the current and modern quality of fetal imaging in terms of describing the location of the lesion better. So thanks for your attention.
Thank you, Gregor. Brilliant images as usual, and unbelievable MRI and the follow-up. It's a tractography, not only tractography, but the follow-up and relationship of hemorrhage, what kind of restriction it can lead, and what kind of your white matter injury it can lead to, and how to detect them, and how to prognosticate. As you said, it's still uncertainty which prevails. You cannot be certain in all the cases which you showed in your last case. So there are a few questions. I think we will answer those questions by all panelists. We have Dr. Dario, we have Dr. Karina, and we have Dr. Gregor with us. Let me ask first of few questions. Let us start from the questions from Shiraz from Iran. Have you ever used any sedation to reduce the fetal movement during MR? Over for you, Gregor.
We are not using sedation. If I've ever used it, I have to say yes, but it's probably in less than 1% of our cases. It's really more the anxiolytic effect of benzodiazepines we are using here when the mother is very claustrophobic, and sometimes it works with some benzodiazepine administration, but usually we do not use that. Other groups are using sedation. I have to say, with sometimes very nice images. Diat Benzira has been mentioned today already by Karina. The images are brilliant. I think she has a higher rate of using sedation. So it depends on your local threshold to use it.
Thank you. Now one more question for Dario, but he has already answered this question during his introduction. Gabor from Hungary, asking that congratulations for establishing Fetal Brain Society. What might be the prenatal incidence of intraventricular hemorrhage, which may be detected or undetected? You should unmute that, Dario.
Thanks for the question, Gabor. It's a challenging question because you know that most of the overwhelming majority of germinal matrix hemorrhages go undetected. Those which are limited to the germinal matrix. So I wouldn't dare mentioning any figure. I only would like to underscore the condition that partly Prashant addressed in his talk, that are highly associated with cerebral and cerebellar hemorrhage, some of which are genetics, so we may reach the final diagnosis only after diagnosing the hemorrhage, but some other conditions such as severe IUGR or some procedures, intrauterine transfusion or lasering, we do know that lead to pressure imbalances, and in those cases it is always there is a must to go for neurosono, both to detect cerebral lesions being there before the fetal therapy, and to go for fetal neurosono follow-up just after fetal therapy, so that you can pick up most subtle hemorrhages, especially in the posterior inferior cerebellar artery territory, which are of usually very limited clinical relevance, and they tend to occur due to these pressure imbalances, and then maybe subpial ones that Gregor brilliantly showed before, associated with pressure imbalances after intrauterine transfusions or lasering for TTTS.
Okay, there was one question from Siddesh from Mumbai. He also mentioned what is the mechanism of ICH after IUD. IUD, I think Dario has already answered the question. Anna from Finland wants to ask, hello, excellent lecture. Why mother who is having cholestasis can have hemorrhagic lesions? Any reasons for that? Well, there are a few things. Let me answer this question. The bile, when bile goes up, but the bile level in cholestasis goes up, it has got a typical affection for the veins, which is going to create a constriction, and eventually it will also attach to the placental vasculature, and it will also cause constriction. And that constriction lead to hypoxia, and maybe the blood pressure changes, and which can lead to the hemorrhage. That's what which is mentioned, but the exact cause is not known. And I hope I have answered your question. Next question is by from Rwanda, by Kegel. In those cases where the intracranial bleeding leads to hydrocephalus, is there a way to stop the bleeding or reverse this process?
No, to stop bleeding, no, of course. To reverse the process, most of the therapies or the attempts to obstructive hydrocephalus are dating to the 80s and 90s, and were a completely slaughter of these babies. So there is no approach that has been approved so far to treat these cases. There have been some attempts now to derive very severe cases in utero to put some shunts in, but these are still uncontrolled and very selected cases, anecdotal cases. So there is not a universally approved approach to limit the sequelae in these cases, especially considering the fact that most of the cases, the sequelae are related to the white matter necrosis and less so much so to the worsening of hydrocephalus. A nice approach is devised in the early neonatal period, and this will be addressed by our neurosurgeon in his talk just after the break, because you will have temporary diversion measure devices that allow for the cerebrospinal fluid to clear up, so that you can then decide with less pressure on your shoulders whether you need to go for a ventriculoperitoneal shunt, or in some cases you may also use cardiovasculostomy, but that's in the next talk.
Dario, there is a specific question from Chandar to you. What was the etiology most common in your series, and all were after 20 weeks?
There was only one at 19 week, germinal matrix hemorrhage, and the overwhelming majority were idiopathic, meaning that there was not a significant relationship, and then few each were either parvovirus, CMV infection, until now, because now with the valacyclovir administration, we will see much less severe brain lesion in these fetuses, also in the infected ones. There were a few cases of genetic mutation of call 4A1 and 4A2, and there was an interesting case in which was related to a vitamin K deficiency, and at the same time, it is in our book, the last edition of our book, and it had at the same time developed both a Binder phenotype, which is a typical facial appearance with a flat face due to midfacial hypoplasia, which also has a very heterogeneous etiology, but one of the etiologies was confirmed to be vitamin K deficiency, either as an acquired condition or also based on some genetic single gene mutations. And in this case, there was a single gene mutation which was responsible at the same time both for the Binder phenotype and the concurrent subdural hemorrhage.
Thank you. There was again question from Gabor from Hungary. What might be the source of vitamin K deficiency? I think Dario has already answered your question. And one more question to Karina by Chandar.
Prashant, if I can add, sorry to interrupt you.
Please.
Another important source, it's very rare, but it's another important source, and this will be addressed in our ISO course, which is end of November, also online. For those of you who want to participate, you can look at the ISO website, and you will find our ISO approved course, and Karina will be there as well. Is very severe and early hyperemesis gravidarum. And those cases, in some of those, you may eventually have acquired vitamin K deficiency sequelae, including hemorrhage.
Chandar wants to ask question to Karina. In severe IUGR, why do we get cerebellar hemorrhage? Karina.
This is a great question because we don't really know the answer. I really don't know how to explain neither for the supra or for the infratentorial hemorrhage specifically. But in fact, and we see more supratentorial abnormalities or vascular insults than infratentorial, probably because of the week of susceptibility, as the cerebellum is more susceptible to earlier gestational ages than and the severe IUGR, and especially the severe vasculopathy of the IUGR, will be present normally later on in pregnancy in cases without genetics. So I would throw an idea that it may explain why we see less cerebellar commitment than supratentorial. But we don't really understand the specific abnormality. We just know that the hemodynamic changes that these fetuses undergo, so they will lead to instability in the cerebral flow in different portions of the brain, and the infratentorium may be affected as well. I don't know, Dario, if you want to add something else, but I don't know something specific about the pathophysiology of intracranial bleed in vascular or placental IUGR that can be established for sure.
No, none that I'm aware of. Placental pathology and thrombus formation there may trigger this effect.
Yes,
and the weakest part of the brain are always the same, the cerebellum and the germinal matrix.
Thank you. Now one more question. I think we'll attend two questions and then we will close this session. Dr. Virada from Samson Night, Thailand wants to ask, thank you very much for really wonderful presentations. I would like to ask, since single intrauterine fetal death in monochorionic twin pregnancy can lead to cerebral injury, could you recommend MRI or ultrasound technique to detect early signs of acute cerebellar injury in surviving fetus? What will you recommend? Is it ultrasound or MRI or both? Where's your choice? Both. Gregor, do you want
but it depends on the timing, because if it's less than 20 weeks, I want to listen to Gregor, but probably ultrasound is much more performing. And if you have to scan the second fetus pre-lasering in ATTPS, which is the distance from the cervix, you do not do transvaginal, and there's a lot of fluid. There might be a possibility, if it's not moving too much, that MRI on the other side may be more indicative.
One of the great contributions of the early ultrasound will be the MCA changes. Then we can see them very early. And I think before we see the damage itself, I think it's one of the main contributions close to the co-twin death. But theoretically, if we are speaking about the way to see the MRI, will see the damage before us.
Gregor, would you like to add something to
well, yeah, I think before 20 weeks it's hard. partly because also we have not done it really, and there's no data there. In fetal, after fetal laser, we in Austria are seeing the cases which are done here systematically. At different time points, I have to say, sometimes early, sometimes late. The sequence which is very important for the early ones is the diffusion weighted sequence to see the diffusion restriction of the brain. However, I have seen now quite a number of cases, and it seems that the chance of picking up these very, very early acute changes are rather low, because you don't really know when they are occurring, and you have to be sort of really lucky, even with MRI, that you recognize them. But I feel in general, if you add the MRI of the procedure, it gives you a little bit more. I mean, it might be that you have seen everything on ultrasound, but it gives you more confidence that everything is okay.
Okay, thank you very much, all faculties, Karina, Gregor, and Dario. Let us move further because we are running short of time. Still, there are congratulating the Fetal Brain Society and Dario and the entire team for organizing such a wonderful webinar. That's all many hundreds of messages which are going on. But we will move to the next session about the prognosis and the management part. So what we have in our kitty for the next is about the neonatal management of intraventricular hemorrhage. That is none other than by Pierre Tilly. And Pierre Tilly, he's a neurosurgeon in Italy, and he's going to discuss with us what kind of treatment which we can offer after the birth if fetus is suffering from intracranial hemorrhage.
Good morning, everyone. I'm Gianluca Piatelli, Director of Neurosurgery at the Gaslini Institute. I thank Professor Pradini for the kind invitation, and I apologize for not being connected with you live, but I'm returning to Genoa from the National Congress of Neurosurgery, and for this reason I had to send you my previously recorded report. I will therefore tell to you about the management of the preterm infant with intraventricular hemorrhage. About a quarter of preterm infants have an intraventricular hemorrhage, and it is in the terminal vein of the germinal matrix that the hemorrhagic event typical of the premature infant originates. The venous origin of intraventricular hemorrhages is dependent on the conformation of the vein with a U-shape that can promote neurostimulation, are recently been confirmed by MRI conducted by our neuroradiologist, specifically Dr. Domenico Tortora, in line with an increased risk of intraventricular hemorrhage in condition of congenital hemophilias that favor microthrombosis and venous stagnation. Most newborns have a spontaneous resolution, but there is a fair percentage that may encounter problems that require neurosurgical procedure. This depends on the degree of bleeding, which will then also affect the prognosis. The most commonly used classification for intraventricular hemorrhages is to be divided into grades from 1 to 4, where grade 1 corresponds to a hemorrhage limited with the subendymal germinal matrix. Grade 2 is represented by intraventricular hemorrhage in the absence of dilatation. Grade 3 is characterized by acute ventricular dilatation, while grade 4 is defined by the presence of parenchymal venous infection. The risk of intraventricular hemorrhage increase with decreasing gestational age. In surviving children born at 25 weeks gestation, the incidence of severe form of intraventricular hemorrhage varies between 10 and 25%, while in children born after the 28th week this form are found in less than 5% of cases. About 33% of the preterm infants can develop post-hemorrhagic hydrocephalus, and it is obvious dependent on the severity of the bleeding, neurosurgical management, or for becoming extension. In our experience, in fact, 35% of newborns require a neurosurgical procedure, of which 35% require a definitive ventricular peritoneal shunt. The extent of ventricular dilatation may be different, and we can assess this using ultrasound and MRI, which allows us to avoid the administration of ionizing radiation on newborn. Brain MRI is the gold standard for the evaluation of brain injuries associated with the prematurity. In addition, magnetic MRI make it possible to perform in a simple, reproducible, and reliable way in measuring the various brain structure, which correlate with the most sophisticated technique of cerebral volumetry. Sorry. And in less than 5 minutes, MRI using specific sequence allows us to better frame the newborn with an intraventricular hemorrhage. The ultrasound and an examination that can be performed by a dedicated personnel directly in the neonatal intensive care unit will then be of support to assess the evolution of the hemorrhage, but above all the ventricular dimension in the days following the event. Hydrocephalus can be obstructive, a blood clot occluded the aqueduct of Silvio or the outlets of the foreventricle. In this case, there is an indication for endoscopic treatment of third ventricular cisternostomy. But more frequently, it is hydrocephalus due to lack of CSF resorption at the level of the generation of the pacchioni, linked to superficial hemosiderosis. In this slide, you can see a summary of the pathogenesis of post-hemorrhagic hydrocephalus. It is important to avoid this phenomenon of fibrosis or arachnoiditis related to hemosiderosis. Instead, needed to clean the cerebrospinal fluid from the degradation process of hemoglobin. The neurosurgical approach therefore becomes important. Regarding the technique proposed in the literature to obtain this result, we have several, and as you can see from these two slides, numerous published reports. Some authors compare the different techniques with regard to the effectiveness. In this slide, you can see a summary of the different therapeutic opportunities proposed in the literature. At the present, it has not been established what is the optimal treatment nor the optimal time for treatment. In our institute, the placement of a long-lasting external CSF derivation is the treatment of the first choice. The external CSF lead is positioned when the ventricular index is greater than 97% for gestational age, plus 4 mm in accordance with Levin. If the progression of ventricular dilatation is not effectively treated with external ventricular drainage after performing the repermeabilization test, reducing the daily CSF drainage after obtaining a normalization of CSF parameters, a permanent ventricular peritoneal shunt is then placed. This is our roadmap. When a progressive dilatation of the ventricular stem is observed, the external CSF shunt derivation is immediately positioned. For more than 40 years, we have been using a patented device at our institute, created by my first teacher, Dr. Andreusi. To perform the procedure, a ventricular catheter is associated with an MRI-compatible anti-displacement device
Dạ
consisting
cho em
of
xin
a
cái password em
cylinder
sửa
with
kết
a
quả
butter
xíu.
plate and a washer fitting
Một
the
một
cylinder
không
plate. The
hai
catheter is fixed to the thecal bone
B
of the
nhỏ B
anti-displacement
nhỏ B
device to
lớn
form a
A
mechanical
nhỏ
bridge
A
between the
cộng A cộng.
intracranial and
Rồi dạ
extracranial
rồi được.
space, preventing a catheter dislocation and keeping the epidural and the extracranial space divided. Direct contact between the ventricular catheter and the skin is prevented to reduce the potential risk of infection. The device has been specifically developed for pediatric patients younger than 30 years to prevent any CSF leakage. The 2.6 millimeter in diameter of the hollow bolt has been designed to precisely fit the ventricular catheter with an outer diameter of 3 millimeter or more. The elastic property of the catheter itself allows it to complete adherence to the internal wall of the screw, reducing the risk of dislodgement. A notch on the top of the screw allows one to cannot suture over the catheter to provide further fixation. It is a minimally invasive approach that allows us to solve the two problems that are commonly encountered in the placement of an external device in a newborn. For example, there is no contact between the skin and the ventricular catheter. The CSF collection takes place in a completely closed system that allows the CSF to be cleaned. The screw with the washer has limited cost. Antibiotic catheters are currently also used for infection. As the anti-displacement device should be implanted over a bone surface, but the incision and underlying craniectomy must be performed more laterally in newborn infants given the presence of the anterior fontanelle. The dura mater is gently detached with a bundle sector, coagulated and incised at the center of the craniectomy. These are the different states of position of the external CSF derivation. The ventricular catheter is connected to a closed CSF collection system, which allows for CSF test the ability to measure intracranial pressure and change the amount of daily ventricular drainage. This is our first series of infants who underwent the AVD over 30 years and evaluated the result. There are about 100 patients of a low weight and with gestational age not exceeding 35 weeks. In 61% of cases, they are with births. It was important for us to get the control of hydrocephalus immediately and to insert the external ventricular drainage as early as possible, from 2 to 7 days from the onset of hydrocephalus, on average around the 8th day of life. AVD was maintained for a long time, no less than 1 month, with a maximum of approximately 45 days until normalization of CSF parameters, intracranial pressure, and ventricular volume. Once these results were obtained, we then proceeded with the repabilization test and indicated the removal over the external ventricular drainage without the placement of a shunt or the implantation of a definitive shunt. In our series, 70% of our newborn are shunt-free, only 30% underwent ventricular peritoneal shunt. The complication is rare. Compared with other similar series, we can see that the result we obtain is certainly positive. We all know the problem related to a shunt dependence with the need for multiple revision of the implanted system, as well as the clinical neurological outcome that we see summarized in this slide. In this slide, I summarize the flowchart regarding the management of post-hemorrhagic hydrocephalus in the preterm. The surgical implantation time is short, as well as the subsequent removal. Most of the patients who require the definitive shunt are implanted late. The criteria for the removal of the external lead are listed here. This finding was confirmed by our recent article where in a series of 35 infants with post-hemorrhagic hydrocephalus treated by us. Those operated on yearly had required the placement of a definitive shunt in a much lower percentage, and the neurocognitive outcome was certainly better than those who had received a definitive CSF shunt. This is schematically our surgical roadmap, and the distinctive feature of our long-term external ventricular drainage, not sudden but progressive and gently physiological intracranial hypertension reduction minimization, continuous long-term ECG monitoring, possible to optimize the ongoing amount of the drainage. It's very useful during neonatal care because it enhances CSF washing and removal, moreover the external removal of small clots. This long-term washout function reduces inflammation, free radical factors, and prevents post-hemorrhagic disorder of fluid circulation. So the constant and direct control over the drainage and ECP allows better general nursing, limits white matter damage, and seems to improve neurological outcome. We can monitor and detect chemical markers of the onset of infection complication. This approach already allows significant decrease of the infection. So we can slowly obtain CSF normalization before external ventricular drainage removal. We perform a safe and progressive reduction of the drainage until zero for a few days. The observation of a normal and stable ECP, a satisfactory clinical recovery, and the absence of ventricular dilatation allow the use to remove the drainage without performing endoscopy or rebushant in 70% of cases. Wound and skin problems as well as CSF leakage are practically absent because the device is watertight and the catheter is completely isolated from the surrounding skin. In case the endoscopy ventriculostomy is required, AVD is maintained in order to obtain safe post-operative management and avoid dangerous ECP increase. In conclusion, well-designed multi-center trials eventually produce evidence to enable the surgeon to provide his most vulnerable patients best practice to minimize perioperative complication and the permanent shunt dependence, and most importantly, optimize long-term neurodevelopmental outcome. Post-hemorrhagic prevention is possible to achieve the best decision-making process in order to prevent both hydrocephalus and neurodevelopment impairment. I thank Professor Palladini and Professor Amenghi for the collaboration we have had in all these years. For those interested, I would like to remind you of this important international conference, the second that we organize at the Gazzini Children's Hospital on a topic of vascular pathology typical of the neonatal and the pediatric period that concern the management of the veno-vein malformation.
Thank you now, Dr. Fetal Stroke, despite his flu, as we all have heard from his voice. And now I ask Prashant and his group to project the second talk by Dr. Hasman regarding the prognosis of IVH. Then we will have the final discussion and closure of this webinar.
Good morning. I'm Oran Hassan from Israel. I'm happy to be here again in this unique and exciting forum. And sorry I can't be there live. My talk will focus on neurodevelopmental outcomes of perinatal hemorrhagic stroke. So, intracerebral hemorrhage in the perinatal period is a heterogeneous disorder with multiple terminologies, locations, and mechanisms. So it can be intra or extraaxial, can be supra or infratentorial, and it may result from multiple etiologies. It can occur prenatally or postnatally, and this is often grouped together as the perinatal period. And although there are often different patterns of hemorrhage and mechanisms, there are multiple commonalities between prenatal and postnatal intracranial hemorrhage. And in many instances, it is a continuum of the same disease. And therefore, although the data on prenatal intracranial hemorrhage is limited, we can retrieve a lot of information from the postnatal world and data. So, prenatally, intraaxial hemorrhage is most common, and IVH is the most common type of hemorrhage diagnosed in utero as well as in preterm infants. And this is because it arises most commonly from fragile capillaries in the subependymal germinal matrix. But one of the differences between prenatal and postnatal intracranial hemorrhage is that we're missing the clinical part. So we might diagnose the hemorrhage very early and watch its evolution in utero, or we may diagnose it in very late or chronic stages and watch its sequelae. So recognition of prenatal intracranial hemorrhage represents a significant clinical challenge in terms of counseling. And the major challenge is not because we don't have the data, but because oftentimes we don't know which trajectory is this patient going and what are his or her repair mechanisms are like. So small intracranial hemorrhage may undergo spontaneous resolution over time, while large intracranial hemorrhage frequently causes aqueductal obstruction and severe ventricular enlargement, often requiring neurosurgical intervention, or it can be associated with infarction and destruction of the white matter surrounding the ventricles and result in a periventricular venous hemorrhagic infarction or in later stage in porencephalic cyst. And in ultrasound, the parenchymal lesion, at first looking as a triangular fin-shaped periventricular hyperechoic lesion, also called the iris sign, and then secondarily grows to join the ventricles, finally merging into the original germinal matrix hemorrhage. And this can occur from a few hours up to a few days after the initial germinal matrix hemorrhage. An important thing to note is that the motor signs will not be evident following birth due to the bilateral innervation from the motor cortex during fetal and early neonatal period. And then during the first few months of life, there is pruning of the ipsilateral projections and increasing dominance of the contralateral projections from the motor cortex, and therefore the parents will often notice the motor deficits at around 3 to 4 months of age when the child starts reaching for objects. And if we compare this to arterial perinatal stroke, periventricular infarction is more likely to present with lower extremity weakness compared to arterial perinatal stroke, in which the arm is usually more or as involved as the leg. And this happens because the descending motor tracts to the legs are closest to the ventricles, and often this causes delayed diagnosis of PVI following birth. And then with lateral extension of the lesion, there may be arm involvement, and this may be caught up early on. The data in this slide is mainly taken from postnatal neonatal ischemic stroke, but still it is important to note that the motor outcomes are different between different types of stroke. So for PVHI, highlighted in blue, the rates of motor disabilities are extremely high, but less language cognitive disabilities and less occurrence of epilepsy. So these children with PVI typically have largely normal cognition, but they will develop hemiparetic CP. And what you can appreciate that those with neonatal hemorrhagic stroke, highlighted in orange, has better prognosis. You can see here all the blue arrows here, and they have better prognosis on all subscales. But this is probably due to the different distribution of hemorrhage location being more commonly extra-axial in term infants than IVH, as we usually see in preterm as well as in fetuses, and therefore this data does not reflect fetal data. So for perinatal intracerebral hemorrhage, the prognosis from the existing literature is really hindered by a mixture of terminologies and cohorts. There are a diverse hemorrhage type and causes, including the inclusion of hemorrhage resulting from hypoxic ischemic encephalopathy, meningitis, and the variation in the timing of the neurological assessment. But generally speaking, if we talk about IVH, then the clinical outcomes really depends on the rating of the bleed and the presence of concurrent white matter injury, and then the other complications, which include post-hemorrhagic ventricular dilatation and parenchymal infarction. And interestingly, IVH, if it's not accompanied by a white matter injury, there is only a slight increased risk of major developmental impairment, whereas IVH accompanied by white matter injury has a strong association with cerebral palsy, with impaired motor and cognitive development. And another very important point is the timing of neurosurgical intervention, which can also affect the neurodevelopmental outcome. And we know from data for preterms that the earlier is better, and there is a need for a follow-up assessment on the development of post-hemorrhagic hydrocephalus, including in utero. So for parenchymal hemorrhage, the outcome really depends on the hemorrhage site. If there is a hemorrhage in the thalamus, particularly the posterior thalamic area, there is an increased risk of epilepsy and electrical status epilepticus in sleep. Cerebellar hemorrhages, if they're small and tiny, those that you can see only on MRI, usually they're not associated with severe outcomes, where for larger cerebellar injuries, they can be associated with motor sequelae and with autism spectrum behaviors. And of course, the background risk factors and abnormalities or the causative factors such as meningitis or hypoxic ischemic encephalopathy, genetic alterations, or sinus vein thrombosis causing increased ICP can also alter prognosis. What happens in the fetal IVH world? the available data had mostly come from a small case series. And this is the meta-analysis on antenatal GM-IVH published by Adam Kirtan and his group from Calgary on 240 cases from 80 studies. And important to note that the median age of follow-up was 12 months. And what they had shown is that mortality was
Chị, cái
around
này chỉ là nang
30%.
phận thôi đúng
However,
không?
the
Hay là
natural
bể
mortality was only
đâu phải bể phận
50% of
ngoài
those
xoang đâu
because
đúng không?
50% underwent
Nang thôi hả?
termination of
Vậy mà
pregnancy.
sao nãy em
They
cắt
also showed
em
that
tưởng nó
for
là
grade
hả
1 and 2
phận ứ
IVH
nước độ
impaired
1.
through sequelae, and in fact,
Thôi
developmental
thôi cái
delay
này
was not
tại vì
described in
nói
any
vô
of
tự
the
nhiên cái thấy
children
nó
with
nói vô cái bể
grade 1
thận.
or 2 GM-IVH, and this could be
Nè cái này nè.
due to mild delays in those
Để cho ông
infants
nhỏ đi
that
chụp
are not
CT.
detectable so early at 12 months of age, specifically for the cognitive issues. They also showed that half of fetuses with post-hemorrhagic ventricular dilatation underwent shunt after delivery, and that shunt placement was associated with in utero progression. But what was really striking is that fetal outcomes were really similar to that of preterm infants, and in terms of PVHI, similar again to preterm infants. Developmental delay was noted in 50%, and there was a high burden of motor impairment, with about 75% of those with PVHI having motor impairments, and this was regardless of whether they were born at term or preterm, and epilepsy was also relatively common. And this got a commentary from Linda DeFries in the issue of DMCN, highlighting that the overall mortality as well as the morbidity were not dissimilar to preterms with GM-IVH and PVHI. So this is our experience on the neurodevelopmental outcome of perinatal and peritoneal hemorrhage in both fetal and neonatal period. And the strengths of our data is the prospective evaluation of neurodevelopmental outcome, also using objective measures, and we excluded factors that may alter prognosis, such as meningitis and ischemic encephalopathy, to really gain a good understanding of the direct association between intracranial hemorrhage in the perinatal period and outcome. The neurological outcomes that we assessed, including rates of CP, remote epilepsy, vision impairment. We used a pediatric stroke outcome measure, which is an objective and specific outcome measure that contains many testing items suitable for newborns until adult ages, and it measures basically the neurological deficits and function across multiple subscales, including sensory motor, language production and comprehension, and cognitive and behavioral subscales. We also calculated a pediatric modified ranking scale, and we then further classify the neurological outcome based on PSOM according to severity, and this was based on a real-life functional status. So we categorized the PSOM scores into good neurological outcome, and these were children with normal or only mild impairment, which do not result in absent function, and poor neurological outcome, which included moderate to severe impairment, which results in absent function. We also compared between prenatal and postnatal diagnosed cases and reviewed neuroimaging to correlate them with the neurodevelopmental outcome. And what we saw is that according to PSOM, most of our patients in our cohort, about 60% had a good functional outcome, and 40% had poor neurological outcomes. And this really highlights the remarkable recovery following early brain injury. However, still 40% with poor neurological outcomes, about 40% with CP, almost 20% with epilepsy, and 46% of those with IVH with post-hemorrhagic ventricular dilatation, and most of them underwent at least one neurosurgical procedure. And the predictors for poor neurological outcome at presentation as well as follow-up included post-hemorrhagic ventricular dilatation, bleeding in the vermis, white matter loss and Wallerian degeneration, abnormal myelination in the oblique, patients with multiple types of hemorrhages, and we did not see that bleeding in the posterior fossa, basal ganglia, or thalamus by itself was associated with poor neurological outcome, but that residual structural damage to these areas on follow-up MRI did correlated with poor neurological outcome. Another interesting finding that we saw is that PVHI was associated with sensory motor functional limitations, but not with worse total neurological outcome or scores on PSOM, and this again echoes the results from these large meta-analysis that for PVI, the major disability is motor. When we looked at genetic diagnosis, the presence of genetic diagnosis was not significantly associated with poorer PSOM scores, and this could be related to the relatively small number of patients who underwent genetic testings and not enough power, or the fact that we included various types of genetic abnormalities in this category, including genetic coagulopathy, and of course, genetic coagulopathy and O4A related disorder have an obviously distinct neurological prognosis, so probably just an undercover. And this is a correlation map illustrating the variable associations with PSOM total scores and subscales. And we did show that PSOM scores correlated moderately with IVH grade and with anterior horn width, which was inversely correlated with PSOM scores. We did not show any association between patients, between any perinatal comorbidities to poor neurological outcomes. However, we did show that younger maternal age during pregnancy was associated with poor neurological outcomes according to PSOM, and it correlated with worse cognitive and behavioral PSOM scores. So these are just some example. This is a neonate with subdural hemorrhage due to factor 10 deficiency, and you can appreciate that there is complete resolution of both the supra and infratentorial subdural hemorrhage with no resultant posterior fossa abnormalities, and he got a PSOM score of 0 and a good neurological outcome. And on the contrary, this is a 9-year-old boy born at term via vacuum delivery, had a posterior fossa bleed, including Vermean bleed and subdural hemorrhages related to CSVT due to polycythemia, and he had a VP shunt insertion with multiple revisions, and the follow-up MRI showed this Vermean atrophy and this focal thinning of the corpus callosum, and he now functions with atactic CP. He has severe ataxia, he has repeated falls, he walks with a walker, he has a borderline IQ, he's verbal, and he attends special education, but he got a poor neurological outcome. And this is a baby boy born at term following normal pregnancy and delivery, and upper scores were normal, and then at the 4 hours of age, he had severe apneas and seizures that required 3 different anti-seizure medications, and imaging showed evidence of subpial hemorrhage on the right temporal lobe with mass effect and venous infarct, as you can appreciate here, with a diffusion restriction in the area. His workup showed von Willebrand disease. He had a normal exome, and he's now 8 years old and has completely normal development. And this is a 2-day-old term baby boy with a right GM-IVH occurring during fetal life with evolution into post-hemorrhagic ventricular dilatation in utero. He was born and underwent neurosurgical intervention at his 3rd day of life. He's now 8 years old, and he has hemiparetic CP with combined language disorder, ADHD, and learning disabilities. and he received a poor neurological outcome. And this is a very sweet child born following normal pregnancy and delivery. And at 5 months of age, parents noted asymmetry of movement and use of the right hand. And this is his MRI showing a presumed PVHI and some remnants of IVH. And he started walking at 1.7 years. And he was diagnosed with hemiparetic CP, but he has normal cognition, normal schooling. His workup showed homozygosity for MTHFR, but he had normal whole exome sequencing, and he got a good neurological outcome.
Bây giờ phải ghi sao cho cái ứng nước hợp lý.
And this is a patient showing classical PVHI, diagnosed at 22 weeks gestation. She has a normal whole exome sequencing, and at 1 year of age, she has completely normal neurological examination and development, so still needs follow-up, but as of now, good neurological outcome. And this child presented with presumed perinatal PVI. He did the MRI due to headaches. He has no motor impairment. He had normal whole exome sequencing, and at 6.5 years old, he has a good neurological outcome. And this is a term-old baby boy with hemorrhagic venous infarction of the left thalamus here due to venous thrombosis obstructing the vein of Galen here with related bilateral IVH. There were no risk factors identified. He did not undergo genetic testing, and he has some mild neurological impairment, but he has mainly mild language and cognitive delay, and he got a good neurological outcome. And this patient was a 1-year-old term baby boy with, again, with hemorrhagic venous infarction of the left thalamus and bilateral IVH due to sinus vein thrombosis, and he tested positive for MTHFR homozygosity, factor V Leiden, and prothrombin mutation. His whole exome sequencing was negative, and he developed very severe refractory epilepsy, and he has a poor neurological outcome. Although he has no motor impairment, he has language issues and cognitive behavioral issues, and he got a poor neurological outcome. And again, the take-home message here is that epilepsy is a modifier of outcome and can be predicted by the involvement of the thalamus to some extent. And this is a term baby boy presented at 8 days of life with a pontine bleeding suspected to be due to a vascular malformation, but was never proven. Hematological workup was normal. He did not undergo whole exome sequencing, and he's now 5 years, and he has a very severe neurodevelopmental delay and extremely abnormal neurological findings with cranial nerve palsies, with vision, hearing impairment, hemiparesis, and ataxia, and low functioning autism
nghe nói là bắt anh Minh đi, nhưng mà anh Minh từ chối tại vì họ không có trả tiền taxi cho ảnh, mà cũng không cho ảnh ngày bù nữa, nên là anh không chịu làm.
Vacuum delivery and had mild hypoxic ischemic encephalopathy. He was also born SGA, and prior to birth he had progressive microcephalus. And you can appreciate here the multiple types of hemorrhage, and the lack of normal myelination in the area of the plic. And he underwent whole exome sequencing, and he had COL41 mutation. He also has cataract, and he has very
nghèo quá trời luôn mà anh Khôi vẫn trả tiền đàng hoàng. Taxi nó có hoặc là taxi hoặc là có xe đó không?
After showing you the last case, I'd like to finalize by showing you 2 cases that highlight the complexity and the understanding of the genotype-phenotype correlations and the effect of the disorders on outcome as reflected in prenatal counseling. And as whole exome sequencing become more prevalent prenatally, we will be increasingly encountering those cases. And this is a 30 weeks gestation fetuses with an incidental finding of a COL4A2 deletion on CMA, and the MRI, the fetal MRI, is completely normal, and this was paternally inherited. from, again, a completely healthy dad who has this very tiny hyperintensity lesion here on T2, very close to the ventricles, and this is his father, so the grandfather, again, completely healthy, has those areas of very mild hyperintense lesions surrounding the ventricles, but again, those patients are completely healthy. And another case of a 30 weeks gestation fetus, again with an incidental finding of a COL4A2 a mutation found on exome sequencing, inherited from the mother, who is completely healthy. And again, she has this very tiny lesion here, which obviously do not cause any clinical stigmata. And we're not really sure whether these mutations are less affecting the protein because they cause loss of function, and they're being evacuated by a nonsense-mediated decay mechanisms rather than accumulating and causing damage. It's really unknown. I would still recommend delivering those babies via cesarean section, as these mutations are still serving as risk factors for neonatal intracranial hemorrhage due to small vessel disease. And just in terms of genotype-phenotype correlations of COL4A-related disease, we know that COL4A1 is much more commonly reported than COL4A2. Is it because COL4A2 is causing the less severe disease? It's really unknown, but half of the mutations are inherited from a parent. We do know that missense mutations in the conserved glycine residues of the triple helical domain are usually pathogenic, and they increase susceptibility to intracranial hemorrhage. There is also a position-dependent effect of the mutation on the phenotype, so depending whether the mutation is in the C-terminal domain or the N-terminus domain, and this may affect the phenotype. But we also know that there is incomplete penetrance and a very wide phenotypic variability, and it is thought that COL4A2 mutations seem to have a better phenotypic spectrum and a milder phenotypic spectrum, but this is really not completely understood. So to conclude, the long